So, endodontic microsurgery will be the theme of the next episodes because the topic is huge. Ladies and gentlemen, welcome to the ninth episode of Endocast. As always, hosted by Ahmed Shauki. Hi, Ahmed.
Hi, Francesca, and by Francesca Cerutti. Last time we spoke about the indication and contraindication of the apical microsurgery.
This time we are examining what comes before the intervention, and we still have as a guest Dr. Ibrahim El Naggar.
Hi, Ibrahim. Yeah, thank you for being with us for the second time. And today we will ask you to help us in preparing the patient and the setup, everything before going directly into the apical microsurgery.
Hi, Dr. Ahmed, and hi, Francesca, and thank you for having me. Yes, today we are focusing on the steps that come before the microsurgery because we need to have like a deep understanding of how to communicate with the patient before the surgery and what to prepare in order to have a smooth and ergonomic workflow.
I like this idea because we don't have to forget that the communication with the patient is as important as a good quality therapy.
Yeah, I agree. And Ibrahim, we want you to explain to us how do you communicate with the patient? How do you explain to the patient the procedures? How the microsurgery will be like? Because a lot of patients ask and are afraid of going into a surgical procedure for just endodontic treatment. So, what do you do in your practice usually?
Patient is referred to you to go for a treatment which is supposed to be endodontic treatment, and at one step you have to elaborate for this patient that this will not go just a normal endodontic, it will be a surgical endodontic. And when he hears surgery, of course he hears or in his mind it comes like the blade and blood and sutures and so on. So basically I have to like do some selection of my words, and one of these selection that I avoid using the words incision and the words bleeding in Arabic, of course, because in English I cannot skip that. And when the patient asks me for elaboration in images, I don't show him one of my real surgeries, and I go for just like diagrams from the book, a soft copies or a soft image that doesn't affect anything about him, because when you know that the patient, when he is nervous, this can affect the surgery itself by increasing the blood pressure and stress during the surgery, and this is very very bad in controlling the bleeding.
Many times we listen to a series of questions that the patient wants to be answered, and I think that we have to be as clear as possible because we want to be sure that they give us an informed consent for the intervention. So, what do you think about this, Ibra?
Um, Sometimes we give them, like, yes, an informed consent, but actually I don't rely on it many times because sometimes I do it for dentists itself. So in this situation, I don't need an official consent, but we can elaborate for the patient. With a normal patient, of course, sometimes we need consent, and they get a lot of question about the surgery. Like one of them is, what is the endodontic microsurgery itself? And for the answer of this question, I tell them that it's a normal endodontic treatment that is better to be done through an endodontist who can work surgery as well and periodontology. So it's like a kind of combined treatment, or it's an endodontic treatment through a surgical access and a microscopic access. Because when they hear a word, a microscopic surgery, they can feel some sort of being comfortable with that. And sometimes, of course, they ask about the success rate. And when we talk about that, it's over 96 over the normal retreatment, which comes to 93. They ask sometimes about if there any other treatment option. I tell them that when we talk about the surgery, it's the the last option, but sometimes I choose between two options, like the microsurgery or reimplantation. Both of them are surgery, but I rely on reimplantation mainly in teeth, which is like upper second molar, lower second molar, and these kind of situations. And the most important thing is that procedure painful? Later on, in the last 2 to 3 years, we started to perform, let's say, a completely painless surgery through the anesthesia technique that we will go through. And of course, they ask as well about how long the procedure will last. And when it comes to this one, it depends on the case. In the beginning, of course, you are going to do an upper center in 2 or 3 hours, but nowadays it's like 30 minutes from anesthesia to finish. There are other questions like, do I have to be accompanied or I have to stay from the work? The answer is most of the time yes, because we need the patient to rest for like 2 to 3 days, not to go and tear the sutures and this kind of stuff. I think these are most of the questions that I get about the surgery from the patients.
That was a good wrap up about the questions from the patient. And another thing, Ibra, since we are clinicians, we are looking for some clinical parameters that can affect the way we go through the surgery. Can you tell us some of those parameters?
Yes, of course. When we talk about the microsurgery, it's not like the normal endo because you have to intervene surgically, basically, of course, because we are having many factors. We are saying it's a surgery, so we have to check the soft tissue. And you cannot rely only on the x-ray because you may see on the x-ray that it's fine, okay, it's fine to treat this too surgically, but when you go to the patient, you cannot retract even the cheek. So the cheek is one of the factors that we test in the microsurgery. Like we ask the patient to close and we put 2 fingers to the top, 2 fingers to the down, and we see if we have enough access to the area. And of course, depending on the type of the gingiva, we have to go through the type of flap because we have like a thin bite type, a thick bite type, and a lot of fear from the recession and so on. When it comes to ladies, we have to ask sometimes about the smile line because when you treat a patient, which is a lady in the mid 30s, and she has a surgery in the frontal central incisor, the first concern is not the success of the surgery. The first success is not to give this patient a scar while she is removing the sutures.
Yeah, yeah,
Not only ladies, by the way.
exactly.
I, yeah.
I would love to not having a scar after the
Of
surgery, and
course.
I'm not a lady, obviously.
Yeah, definitely, definitely. But it's everything is extremely correct, and I think that you pointed out one of the most important things because when I was learning from Fabio Gorni, he said that what made him decide whether he would have done the surgery on that tooth or not was just the possibility with the patient with his mouth closed retracting the cheek if he was able to see clearly the area of the intervention and to have an access, yes, he would have done the endodontic microsurgery. If not, that would have not been an option. So this is extremely important from my point of view, what you said.
Yes, I absolutely agree, and I remember one patient that come that to me, and I examined her, and on taking the medical history, she was having some degree of scleroderma, and that was mean tight cheek, and we couldn't go to the surgery, and we seek other treatment options, as Ibra highlighted. So having a good vision and access to the tooth through the soft tissue and retraction is very important to perform a good surgery.
Yeah, exactly. And Ibrahim, another question. What about radiographic examination? Do you always take a CBCT, or you think that sometimes one can rely just on a bidimensional image?
About that. When you go with your treatment and you have all the data that you need before the surgery, it's always beneficial. Like when you have the 2D, you have the photos for the patient, you have the probing depths for all the tooth around, and you have your CBCT. It's beneficial. But let's be honest that not every surgery case needs a CBCT, but in the beginning of the surgery, you need to do a CBCT before start for many, many reasons that you need to decide the length of the root, you need to decide the area to be resected, you need to know even if it's a through and through lesion and so on. So in my opinion, if I would go to choose between having a CBCT before the surgery or not, of course, every time I would love to go in with a CBCT, but there are some surgeries I did without any kind of CBCT, and these surgeries are mainly in the upper central when we have an obvious problem like he have a broken instrument in the apical area, which is extruded outside and so on. But when it comes to the central incisor, of course, and we have a through and through lesion, we have to go with the GBR and GTR and so on. Of course, I have to ask for CBCT to see the size of the lesion and how big is the problem. But it's for me like 70% and 30%, 70% with the CBCT and 30% without any kind of CBCT.
Yeah, I think CBCT is for sure an important tool that allow us to evaluate the situation, to see the area better. And this was according, of course, to the society's recommendation to take a CBCT before apical microsurgery, because it's not only about the tooth, as you said, and but sometimes the involvement of other teeth, the proximity to some vital structures or important areas, danger zones, as we said. So, of course, CBCT give us a deep insight about the third dimension. But do you think that it can help us also in some other areas rather than evaluation?
Of course. Let's say there are some surgeries that are considered dangerous surgeries, like the one when you do it on the mental foramen, and this is very very common in the area of lower first and second premolar. Okay, you have a close proximity for the nerve, and as well for the mandibular second molar. Sometimes you have the nerve is very very close, and you have to decide. If you are going to do it surgical or you are going to extract the tooth and do the reimplantation. As well, when we talk about the maxillary sinus, like in some cases, I have to treat the patient that have a filling inside the sinus or is going through the sinus. So we have to use the CBCT in this situation to know exactly when to open or when to stop, because sometimes when you cut a little bit higher, you may harm the sinus.
So, up to now, we have seen how to plan, but let's be practical. Which tools do we need to prepare for having no surprises into a endodontic microsurgery procedure?
Okay, I'm using the microsurgical kit from Style Italiano since 2019, and up till now it's very fine for me. It's like I just added one to three instruments beside the kit, and two of them is for the suturing. So the kit is working very, very fine for me. And let me go through the need for other things during the surgery, because it's not about only the hand instrument. We also have other tools that we are going to need. For working to do the surgery right, you need, like we say, the overchest surgical table, because you can put your instrument in sequence that you, and when you remove one instrument, the assistant itself have the possibility and accessibility to return this instrument again back to the position without any stress. After that, we are going to the incision, and for the incision, and as we said, it's a microsurgery, we need to rely on a small size of the blades. For this, I'm using like 15C blade when I have to go inside the papilla, and a microblade when I'm not going to include the papilla in the incision. And of course, one of the most important things in the surgery is the retraction. What can make you nervous during the surgery when the assistant is retracting, and at some sort she decided to slap the retractor and the flap went back to your work. So retraction is very, very important, and we can classify the retraction for cheek and tissue. For the cheek retractor, we use the normal Minnesota, and we have a specific retractor like the Rubenistan for retraction of the flap. The Rubenistan one, we have small size and a large size depending on the flap. After opening the flap and retracting the cheek, we have to go, of course, through the flap elevation. And for this purpose, we are using a mucoperiosteal elevator. I'm using the one from the SIE cat. It's working fine till now without any kind of problem. We have two sides, one which is small and one which is large. The small one is, of course, for the interproximal areas, and the large one is for elevating up the full thickness of the flap. When we talk about that, it's not beneficial to use the 40. I prefer to use a surgical handpiece. I'm using the one from W&H because it's almost designed for the surgical procedure. You now open the osteotomy. About curette, we have to use something which is sided because you need one side to cut in and one side to cut out. And sometimes you the cysts out from the bone. Then now we have to figure out the anatomy inside by using a methylene blue. Of course, it doesn't come in the powder format. It comes in the liquid. You just use like one syringe for a lifetime use. You just take one drop for the whole procedure. Now we have to go for the device, which is the ultrasonic in this case. Depending on different uses of the ultrasonics, I have figured out that the one which is, let's say it's expensive ultrasonic, can give you more stable movement or more stable cutting during the surgery. Unlike the cheap ultrasonics, it can unfortunately damage the root due to unstable movement of the tip during the surgery, and of course, breakage of the surgical tip itself many, many times. When we talk about surgical tip, we are going to talk about a kit which is designed specifically for the microsurgery that we use the whole kit. We open the whole kit during the procedure. We use whatever we want, and after that, we pack it again for the sterilization. Now we have to have a clear vision for the apical part of the root, and for this purpose, of course, we are using the micro mirrors to have a clear view, and we have two options of them, the round one and the elongated one or the rectangular one. For most of the time, if I'm going to use just one mirror, I'm going to use the rectangular one because the round one, sometimes it doesn't go all the way inside. After putting the filling, we now have to compact because some people think that putting a surgery filling is like having the MTA and put it like that. Is unfortunately wrong because if you read that, you may figure out that in the post-op you're having voids, and this is not correct. And you know, voids may sometimes decrease the success rate of the filling. For that purpose, we are using two retro pluggers, but these two pluggers are in the same instrument. One of them is having like a 3 millimeter back and a 3 millimeter lens, and the other part is a 6 millimeters. And after cleaning and finalizing everything, now we have to go for suturing. And when I talk about suturing, I have to say it's a microsuturing because I didn't remember one time I sutured a patient in a microsurgery using a 40 or a 30. The minimum start nowadays is like 50, and we are going up till now for 60. Because the smaller the suture is, the better the healing and the less the scar. For this purpose, we are using a Castro Viego and a micro scissor. This instrument, in my opinion, is a one-time purchase. They are expensive, but you're not going to buy them daily. So it's better to get a good brand other than buying a normal brand and throwing it daily. And that's it.
So I believe that you wrap it up as usual. And if you are a good driver, you need a good car. That's why tools are very important, even with skilled clinician. So thank you for explaining us how to plan the microsurgery and which tools are mandatory to be with us during this delicate procedure.
Yeah, I was about to say the very same thing. Thank you very much, Ibrahim, for staying with us
Thank you.
and for your excellent presentation. And so, guys,
A pleasure.
I hope you enjoyed this and stay tuned for the next episode of Endocast.
Bye.